between those three things, the observation of the movement, the analysis and checking of primitive reflexes, as well as the analysis of something called postural reactions, we get an idea of how well our child or our patient, how well their nervous system is maturing, how the quality in which it's developing. Because Hi, this is Dr. Bill Tortoriello with IMTR Seminars, and today it's going to be a solo podcast dedicated to the DNS approach to pediatrics. I just completed the initial pediatric course or pediatric A course for DNS this past weekend, and I thought I might update you guys on to what the DNS approach actually is for pediatrics if you're unfamiliar with it. So first of all, it is an approach based on functional neurology or neurodevelopment, similar to the DNS approach with adults. It allows us to neurologically examine infants and children. Specifically, it enables us to get an idea of what we would call the developmental age of an infant, regardless of if they're a newborn, a 3-month-old, a 6-month-old, essentially over the first 2 years of life and beyond. What does that physical examination entail? It's 3 things. Observation of spontaneous movement, which is a fancy way of saying watching the child move from a variety of positions on their own to see what they do and how they do it. It is analysis of something called primitive reflexes, which include certain reflexes that every pediatrician probably checks for. And then separately, or the last thing, is something called the analysis of postural reactions. These we'll get into in a little bit, but essentially these are whole body global reactions to a particular stimulus. So between those 3 things, the observation of the movement, the analysis and checking of primitive reflexes, as well as the analysis of something called postural reactions, we get an idea of how well our child or our patient, how well their nervous system is maturing, how the quality in which it's developing. Because unfortunately, as we all know, sometimes an infant or child can be of a certain chronological age that we might have an actual 6-month-old in front of us. However, maybe on their back, they are actually developing and acting and have the central nervous system of a 6-month-old, a healthy 6-month-old. But when you lay them in prone and on their tummy, for example, they might show signs of delayed development. This delay in development is not necessarily indicative of something serious. It's not a red flag. It's not a significant neurologic condition, although it can be, unfortunately. But this type of DNS assessment gives us a window into examining the nervous system month to month to give us an idea of how well this child is actually developing. Specifically developing their ability to move, their ability to attain particular postures, their ability to stabilize, whether that's in the sagittal plane initially or throughout the rest of the planes as they verticalize and develop more. And so it's giving us an idea of quantity, of meaning what they can do at particular ages over development over the first year of life. For example, the human motor development or developmental kinesiology tells us that by 3 months old, a physiologic normal child in supine ought to be able to raise their hips and legs up against gravity and hold it there with relative ease. So that would be something that when I examine and assess a 3-month-old infant or a 4-month-old infant for that matter, I'm going to lay them on their back. I'm going to see what they do automatically. I'm going to see what they do spontaneously on their own. If that child does happen to lift the legs and show me that stereotype that I'm expecting, number one, in my notes and in my head, I'm thinking, okay, quantity-wise, they have what you should quantitatively do as a 3-month-old. DNS, of course, goes a bit further than that because, of course, we are concerned with quality as well. So it's not only can the child attain a particular posture or do a particular movement, it's how well they can do it. Can they do it with quality? The DNS perspective on the quality of a movement or the quality of stabilization does come directly from human motor development. So we know that babies utilize particular patterns of movement, particular patterns of stabilization, and particular postures that do relate to standards of biomechanical norms. So we are visually inspecting as well as palpating infants and children to identify whether or not they are actually utilizing what we know from the objective framework of motor development, if they are actually using that quality stabilization pattern. So not only when I'm examining or watching an infant move, no matter what month they are or how old they are, I'm examining the quantity, what can they do in particular postures or particular months and how old they are, but I'm observing how well they can actually do it. So, for example, from human motor development, this tells us that standard typical rolling from your back to your belly ought to be mature and developed by 6 months old. So, with that knowledge in my mind and taking a history from parents, mom might tell me, oh, yes, my 4.5-month-old is rolling over. They roll over all the time. And I can nod and say, okay, that's fine. And then when I observe them actually roll, most likely a 4.5-month-old might actually flop over from their back to their belly, but they're not doing it with any quality. In fact, they're doing it with poor quality. So this is something to note, to consider. This is the difference between just simply saying, oh yes, I have a 6-month-old and they can roll over in both directions, versus they can perform a turn or a roll from their back to their belly with ideal quality. So this is, of course, something that DNS considers. Second, this checking of primitive reflexes. Primitive reflexes are a standard in pediatric neurology and pediatric assessment. Some of your pediatricians might check a few of these reflexes. Some of them might check more of these reflexes. DNS attempts to consider all of these reflexes and assess them with every visit. Of course, as some of you may know, some of these primitive reflexes will be there on the first day of birth, and most of them will be gone or should be gone and inhibited by about 4 to 6 weeks old. So if I have a 3-month-old or a 4-month-old or an 8-month-old, I can check some of these reflexes to make sure that they are not still present. There are other primitive reflexes like acousticofacial reflex or opticofacial reflex. These don't actually begin for a newborn. For example, acousticofacial reflex does not appear until about 10 days old and does last for the rest of the human's life, even into adulthood. Whereas the opticofacial reflex should begin or should start to present itself at about 3 months old. So within those first 3 months, if I'm checking it, I can check it, but it should not be present. In fact, that test should be negative. After the 3rd month, I expect to see that opticofacial reflex positive throughout the remainder of that child or person's life. There are other primitive reflexes that DNS considers always pathologic. This means, of course, that if we see a positive sign when we attempt to test for these reflexes, we are considering this a red flag. This is something that should not be there. Something like a Rossolimo reflex, something like uprighting support reflex of the upper extremities. These are things that should never be present and that we can check for to rule out more significant pathology. Lastly, that last category of assessment that DNS uses is something called postural reactions. Now, there are many approaches to a physical examination of an infant. There's many approaches to the physical examination of the motor system or the musculoskeletal system or the neuromusculoskeletal system for pediatrics. A lot of them utilize a lot of these postural reactions that are included in a DNS assessment. Technically, DNS uses 7 different postural reactions, or at least considers 7 different postural reactions. We're not going to name or list them all here today, but typically using at least 2, 3, 4 of these reactions to guide our assessment and get a better understanding of how this infant's brain is developing over time is just another piece of the puzzle that helps us get a better understanding of CNS maturation. So, for example, there is one particular postural reaction called Colles horizontal reaction. Some of you may have seen it before, others may not. This is where the child is placed on its side on the table. The doctor will contact and hold the child's upper arm and thigh, and they will quickly lift the child from the table on its side. In particular months and particular ages, we expect to see certain things occur reflexively in that downside arm and the downside leg. For example, a 6 and 7 month old child ought to be able to support themselves through their extended open hand. This is something that naturally occurs in development. So when I do Colles horizontal reaction to a 6 and a 7 month old child, I expect them, when I lift them up and off the table, I expect that downside arm to actually pronate, and the forearm pronates and the hand gets placed onto the table. This is not a voluntary reaction. This is a postural, involuntary reflexive response that is automated and governed by subcortical programs in the brain. Similarly, the analogy holds that by 8, 9, and 10 months, the child ought to be able to support themselves through their foot. So up until 8 or 9 months, when I do that Colles horizontal reaction, I do not expect a 4-month-old, a 6-month-old, a 7-month-old to turn their foot and place their foot down on the ground. But if I observe foot loading and spontaneous movement, and I have a 9-month-old, a 10-month-old, an 11-month-old, and I perform Colles horizontal, I do in fact expect to see that foot turn down and touch the ground as if it were loading. This again is a reflexive response. If I don't see what I know I ought to see, this is a piece of the puzzle that I add in to my assessment. Between taking a look at how the baby spontaneously moves, postures it can attain, the quantity as well as the quality, taking and analyzing primitive reflexes that may have been present, may actually show up as negative, unfortunately, or if a pathologic reaction, if I get a response out of those, as well as that last consideration of what occurs during the postural reactions. This gives us the best possible chance at understanding how well this patient's nervous system is developing. It is the most sensitive way to analyze an infant's nervous system development. Sensitive in terms of, yes, it will definitely pick up signs early on for more significant coordination disorders, neurologic disorders like cerebral palsy. However, it can start to give us signs of more mild, minor developmental coordination disorders like simple developmental delays. And it also gives us something objective to look at when we start or if treatment is necessary. If some type of treatment is necessary, this is a way to do a pre and post examination that is not just purely based on, well, is the child was not crawling, I do a treatment, and now I see if they can crawl. That is definitely an aspect of a pre and post treatment, but having more objective information like the primitive reflexes combined with the postural reactions makes our treatment more effective and gives us more confidence as to whether or not our approach is actually effective and whether the patient and the infant is actually showing signs of improvement. So, if you are interested in treating babies, I do, of course, suggest, I'm biased, I'm a DNS provider, and more specifically, I am a DNS certified pediatric specialist. I do suggest checking out a DNS pediatric course if you have the time. Thanks again. We'll see you next time.
If you enjoyed this conversation and want to hear more like it, then please like this video and subscribe to our channel. You can also stay up to date on our latest seminars on our social media pages on Instagram and Facebook at IMTR Seminars.